Hello everyone. Now I'll be talking to you regarding iron deficiency anemia. It's a very important topic. And in this topic in particular, there are two areas which are really a gray area for most of students, and the two areas are iron metabolism and the iron studies in the laboratory. Well, before I come to these two important areas, let's start with the basic concept about iron deficiency anemia. Well, IDA is the most common cause of anemia in the world. Rather, you can say around 80% of the females in the world, especially in the developing and underdeveloped countries, the ladies are anemic. So, first thing is physiology of iron metabolism. We are well aware that iron is there in hemoglobin. Well, it is there in certain other molecule also. Stop the video, write down the answer. What are the other molecules where iron is present? Quickly write down the answer. Stop the video, write down the answer. Well, the answer is myoglobin, cytochrome. There are the two other molecules which also have iron, but for all practical purposes, hemoglobin is the most important molecule which contain iron. Well, it has 0.34% iron by weight. Now, when we use any acidic media, especially in the stomach, it forms the soluble macromolecular complex of iron in duodenum. How it is happen, what happened, this I'll be talking to you in the next slide. But one thing is there, only about 10% of the ingested iron is absorbed. This is especially in males. In females, this may be around 20% of ingested iron may be absorbed in females. But one more important point, if the patient has severe iron deficiency anemia due to any reason, the amount of absorption may be as high as 30% also. Well, 10%, 20%, 30%. This has a special relevance. It has special meaning. It means iron absorption is being controlled at the level of GIT itself. This is a very important line for you. Normal serum iron level is about 50 to 150 microgram per 100 ml. Simple. With this background, now let's move into factors which really influence iron absorption. Well, if we classify into three categories. One is dietary factors. Now, if the iron is in the heme form, absorption is more. Ferrous salt, which is there in fact in animal molecule, animal food, iron is in heme form, and heme has iron in ferrous form. That's why the HB of animal origin is absorbed much better as compared to others. What is the other one? The factor which decrease iron absorption is ferric salt in plant diet. Point to be noted, in plant diet it is in ferric form, that is Fe3, and in animal it is heme form which has a ferrous. So we can say animal food has ferrous and the plant food have ferric. Now, systemic factor, iron deficiency state. I told you in the previous slide also, in iron deficiency state, iron absorption may be as high as 30% also. Or any condition which lead to increased erythropoiesis. There are so many conditions which can lead to increased RBC formation due to increased erythropoietin. In such cases, again, iron absorption will be increased. Why? Because now demand is more. Same in pregnancy also, demand is more. Or any condition, hypoxia, which indirectly will lead to increased erythropoietin. Okay, increased erythropoietin will lead to increased RBC formation. And when in severe hypoxia, it's constantly high amount of iron absorption will be there. And the best example of this is chronic bronchitis. In chronic bronchitis, there is increased level of iron absorption, and that lead to secondary erythrocytosis. Now, factor which reduce iron absorption other than the plant diet, iron overload state. If the body has enough iron, body will like to reduce iron absorption. Okay, but there is a exception also. In medical science, there is nothing like absolute. And stop the video, write down the answer. In which iron overload state still iron absorption is very high? Write the answer. Stop the video. Well, the answer is primary hemochromatosis. Is a iron overload state, but still iron absorption is more. Rather, it is other way around. Excess of iron absorption occurs uncontrolled, and that lead to primary hemochromatosis. But however, despite being a iron overload state, iron absorption is increased. Decrease erythropoiesis, any condition where erythropoietin is reduced. The classic example is chronic renal failure. In chronic renal failure, erythropoietin level is reduced, and that lead to reduced erythropoiesis, and that lead to anemia. Inflammatory conditions also, the iron absorption is reduced. Now, very, very important question from pathology. Stop the video, write down the answer. Which molecule is very much responsible for reduced iron absorption in any chronic inflammatory condition? Stop the video. Well, the answer of this is hepcidin. In hepcidin is the one, and that's the reason why in anemia of chronic disease, this anemia is there. About this, I'll be talking to you in detail in the coming slides. So we are convinced about this slide where they are talking about factor causing increase and reduce iron absorption. Let's talk more. So luminal factor are also responsible. Luminal factor, acidic pH causes increased iron absorption, and alkaline pH, which is there due to pancreatic secretion, the iron absorption is reduced. Applied. Now what is applied? Let's correlate. That's why iron is maximum absorbed in duodenum. Why? In duodenum, the acidic pH is there. And food like vitamin C, that's why whenever we prescribe iron therapy, it's always better to prescribe with vitamin C, because vitamin C will create a acidic pH, and that will help in the iron absorption in duodenum. Well, factor which reduce iron absorption are alkaline pH, decrease iron absorption by phytate. It is present in wheat. Okay, tannic acid, it is there in tea. Oxalate, high phosphate diet, bread and milk, they all lead to reduce iron absorption, because these molecules, oxalate, phytate, tannic acid, they make a complex with iron with like phosphate. They make phosphate. So these complexes are not absorbed. Similarly, we have a drug called tetracycline. It also causes reduced iron absorption because it also makes a complex with iron. All these are very important questions. Well, now we continue with our discussion about basic physiology. Except for epithelial shedding, okay, maybe mucosal lining shedding or menstruation, there is no other way of iron loss from the body. This is something unique about iron. Majority of the molecule body can shed, can maybe excrete in the urine, feces or other way around. But this is one exception, that the only thing is weak shedding, especially the mucosal lining in the gastric mucosa is the important way of shedding, and menstruation in the female in the reproductive age group, they have a shedding of the iron, but otherwise there is no separate excretion mechanism for iron. So that's why iron absorption is very tightly regulated. That means iron absorption is to be controlled at that level of absorption, because body doesn't have a very effective method of excreting the body iron from the body. So with this background, we move into iron metabolism. What are the source of iron? Is diet. I told you, maybe plant diet having ferric and the heme in the animal food which has ferrous. And old RBC destruction is the other source of iron. That is well known to all of you. Now, dietary iron. I mentioned in the previous slide, it may be in the inorganic ferric form. It is in plants. Okay. And I also mentioned in the previous slide, this ferric, this fun, it can make complex with phosphate, oxalate, tetracycline, okay, and they are lost in the feces. So it means there is one patient who is on tetracycline therapy and he is anemic also. You are giving iron salt. It will get combined, this ferric molecule will combine with tetracycline and go out in the feces. It will be all wasted. So they are not efficiently absorbed, the complex. Now heme, it is there in animal food which is there in the form of ferrous. It is absorbed more efficiently. It does not make any complex with all these. The distinct advantage, that means the animal food iron doesn't make any complex. That's why there is no inhibition of absorption. That's why it is absorbed much more efficiently. So the key word are plant diet has ferric and the animal food has heme, ferrous. So summary of what we discuss. Key word to remember, plant, ferric and animal heme, iron is a summary of what we learned in the previous slide. Now finally, iron has been taken up. Now it has come to the duodenum. So in the plant diet, ferric is there. Yeah, it comes to duodenal lumen. Here it is converted from ferric into ferrous. Okay. This is happening in the stomach and the duodenum. This is done by ferric reductase. Enzyme involved is ferric reductase. So you can say this is ferric reductase, and this convert into ferrous. And this ferric reductase is present in the surface of the duodenal cell wall. Okay, cell membrane to be more precise, because cell membrane. Yeah. Well, this reduction from ferric to ferrous, this is supported by acidity which is there in the stomach, hydrochloric acid, and the vitamin C. The point I mentioned, that this acidic pH is very helpful in converting ferric into ferrous by reductase. That's why the applied is when we give any ferric compound, or whenever we want that more and more iron should be absorbed, antacid should not be given. Because antacid, they are going to change the pH of the gastric lumen. Well, so now in the duodenum we got ferrous, which has come from ferric, and we have heme, which is there in the animal food, and this was brought from the plant ferric into ferrous. Well, now in the duodenum, enterocyte, the cell lining of the duodenum, it will be absorbed by two mechanisms. There is one divalent metal transporter, DMT1, this absorbs ferrous. Heme carrier protein 1, which absorb heme. Remember, the heme molecule will go by HCP1 and ferrous will be going by divalent metal transport 1. They will absorb ferrous. With this background, summary. The summary of the previous slide, ferrous will be absorbed by heme and ferrous. Ferric will be absorbed by DMT. Point to note it will be first converted into ferrous, and ferrous will be absorbed by DMT, divalent metal transporter 1, and heme, which is there in the form of ferrous, will be absorbed by HSP1, heme carrier protein 1. So HSP1 and DMT1 will absorb ferrous, and of course ferric again came from plant, converted into ferrous, but it will enter DMT by ferrous form only. So we got two entry gates. So we can say we got well, this is a much better slide. Same. So we got heme, and that is going enter via HSP1, and in the enter side, heme has come. Ferric converted into ferrous via ferroreductase, which I told you is present in the lining of the cell membrane of enterocyte. This convert ferric into ferrous. This ferrous has been made, and this ferrous will be absorbed by DMT1, and it has come to inside. So in a very lighter way, entry gate for heme is HSP, and entry gate for plant derived ferrous will be DMT. So these two are entering via separate gate. Very simple. At time you go to airport, there's a separate line for the ladies, separate line for the males. Here also separate line for heme, separate line for the ferrous. I think the best day-to-day example I can give to you. Well, now this heme has entered the enterocyte. Even ferrous has come. Now this heme, which has got iron in ferrous, will be converted into free ferrous via heme oxidase. Heme oxidase will convert heme into ferrous and biliverdin, and this will go out, and finally, ultimately, even the ferrous of the heme also has been released free, and this ferrous has already come from the DMT. Ultimately, net result will be the ferrous which is there in the enterocyte. So to a quick recap, that heme is entering via HSP1, getting converted into ferrous, ferric get converted into ferrous, enter via DMT, and ultimately ferrous is there. Well, ferrous has come to the cell. Now, if there is excess of ferrous, iron is there, or deficiency of iron. If iron is in excess in the body, it will get converted into ferritin, which has got iron in ferric form. In fact, this get attached to apoferritin. Ferrous will get attached to apoferritin. In fact, ferrous is again converted into ferric, get attached to apoferritin, and it make ferritin. So ferrous, point to note that if excess quantity of iron is there, this ferrous will get converted into ferric, and this ferric will combine with apoferritin, and it will make ferritin. So finally, it's stored form of ferritin. Now, what happened to this ferritin? This ferritin, which is there in the enterocyte, will stay for 2 to 4 days. In between, if the iron is needed, it can give iron back. But not, then this cell will get shed. We all know very well that duodenal mucosa gets shed in 2 to 4 days. So in excess iron, it will shed out. And in the very beginning only, I told you the only way out of losing iron from the body is shedding of the mucosa. So it will go out. Since the duodenal mucosa is multiplying very fast, that's why there is no chance of mutation in duodenal mucosa. That's why duodenal cancer are very uncommon, because the cells are dividing very fast, shedding out very fast. Well, this happened when the iron was in excess in the body. Suppose the body needs iron, then this ferrous form, again ferrous, will get absorbed via ferroportin. The exit gate is ferroportin. It will go out and come to the blood vessel. This is so now it has come to the blood vessel. Let us say this is the iron which has come to, in the ferrous form, it has come to the blood vessel. So friends, if I have to give a summary of this slide, heme is going in via HSP1 gate, and ferrous is going via DMT1 gate, enter. In the here, heme get converted into ferrous via heme oxidase, and ferrous is there directly also. Now this ferrous may go into the blood vessel via ferroportin, or if there is excess of iron, This ferrous will get again converted to ferric, get attached to apoferritin, and it will make a storage form of ferritin. And this ferritin is there in the enterocyte for 2 to 4 days. If needed, again convert into ferrous. If not, this cell will shed and body will lose iron. Well, we got ferroportin, which is the exit gate of iron from enterocyte to blood vessel. Just to inform you, here iron absorption is controlled by hepcidin. Hepcidin is the one molecule which is being synthesized in the liver. Suppose now body wants less amount of iron to be absorbed. There will be more and more hepcidin. More hepcidin will lead to reduce iron absorption via ferroportin. Ferroportin. I can give you a day-to-day example. We all drive vehicle, maybe my bike, maybe car. In the car we have a brake. Once you apply brake, what happens? The car speed goes down. This is the brake. Hepcidin is the brake, and it will apply on the ferroportin. Okay, so it's a brake which act on the ferroportin. Iron absorption will be less. Iron will be absorbed here. More and more iron will go toward ferritin. But suppose body need more iron, hepcidin molecule will be reduced. That means you are driving car, you want to increase the speed, you will remove your foot from the brake and you press the accelerator. So now the brake is gone, the car will run fast. So now more and more iron will come to the blood vessel. And hepcidin, the one molecule, point to be noted. So what all you have to remember, hepcidin act on which molecule? Ferroportin. What is the function of hepcidin? Reduce iron absorption. Well, now iron has come in the blood vessel in the form of ferrous. Now let us see what happened. So this is a summary, lovely summary of what I discussed in the previous slide. Okay, previous slide. In the enterocyte, ferrous is again converted into ferric, get attached to apoferritin, and it is stored in the form of ferritin, stored for 2 to 4 days. If not needed, shed and goes in feces. But if it is needed again, and that will be again converted into ferrous, and that will be absorbed via ferroportin. Ferroportin, and it will enter the blood vessel. This summary of what we discussed in the previous slide, right? With this background, so as I told you, mucosa of duodenum is shed very fast, hence cancer of the duodenum is uncommon, no time to get any mutation. Well, now role of hepcidin, which I again told you, ferrous enter from mucosa to blood vessel via ferroportin. Hepcidin release from liver act on the ferroportin to control iron absorption. I told you hepcidin is act like a brake in the car. So it is the iron regulatory protein, or you can say it's a brake which control iron absorption. So it inhibits iron absorption in GIT via ferroportin. It inhibits iron release from macrophages. But ultimately, iron is stored in various organs, including macrophages. Macrophages have iron. When body doesn't need iron, hepcidin will reduce iron absorption from macrophage. It will not come back. Macrophage are the iron storage cells in the body. Now, this hepcidin is increased in chronic infection. So this also contributes to anemia of chronic disease. That means less and less iron will be absorbed in any condition of anemia of chronic disease. Rather, it will inhibit. This is a very important mechanism in anemia of chronic disease, that it inhibits iron release from the stored site, is one of the contributory factor in anemia of chronic disease by hepcidin. Now, well, till now I told what I discussed, which have been told in the previous slide. Now iron has come to the blood vessel. So this is the blood vessel. Here is the ferrous, and it is immediately converted into ferric. Now, one very important message for you. Whenever iron crosses any cell membrane, it crosses via ferrous. like from GIT to lumen to cell, it cross the cell membrane in the ferrous form. From enterocyte to blood vessel, again cross in ferrous form. But inside the cell, it gets converted into ferric. Here also in the blood vessel, will again convert it into ferric. Now this is done by ceruloplasmin, which is present in the blood. This will ceruloplasmin, CP, ceruloplasmin. And second molecule which convert ferrous into ferric is hepcidin. It is present in the enterocyte membrane, like this is the lumen. This is the luminal cell. This is the basolateral. This is the blood vessel. Okay, now this hepcidin is present in the basolateral aspect of the enterocyte. Now, and ceruloplasmin is in the blood vessel. Now here ferric combined with okay. Well, this ferrous is converted to ferric by ceruloplasmin and hepcidin. Now this ferric will combine with apotransferrin. This will combine with apotransferrin, and it will convert into transferrin. So this will get converted into transferrin. So transferrin is a combination of apotransferrin and ferric, and this is a iron transport. This by which iron is transported. It's a transport molecule. It will transport a ferric from blood to the bone marrow and the spleen, liver, where we need. So transferrin is a transport form of iron. So now iron goes to bone marrow to make HB, or it may go to the liver to stimulate hepcidin. Now hepcidin, which is a brake, now excess of iron is there. It goes to the liver. Whatever is needed has gone to bone marrow, but extra will go to liver, and now body says, now we don't need iron. So hepcidin will be stimulated in the normal physiological condition. And I told you this hepcidin is going to act in the ferroportin, and that will regulate iron absorption at the level of ferroportin only. So now finally we are getting transferrin, which is a complex of apotransferrin and ferric, will go to bone marrow, liver, and here it binds to transferrin receptor in membrane of this organ. Let us say this is the membrane of the bone marrow. Here we have a transferrin receptor, TR, and here transferrin comes, get attached to transferrin receptor. That means we are getting a complex of T. T is transferrin, TR is transferrin receptor, and this complex is made in the membrane. Now this will enter this T plus TR, this complex membrane, it will be taken inside via endocytosis. What happened? And this molecule has entered via endocytosis, T plus TR. They have entered the cell of the bone marrow. By which process? Endocytosis got attached to the membrane, invagination was made, and finally it entered via endocytosis. Okay, so endocytosis has happened. It enters cell by endocytosis and reaches the cytoplasm. So this is the cell, and here these TR is transferrin receptor, and T is the transferrin, which is a combination of ferric and transferrin. It will again break down to ferric and apotransferrin. AP stands for apotransferrin. These two will go back. They go back outside the cell. Transferrin receptor will again go to the cell membrane, and this apotransferrin will go back to the blood and will get more and more iron. The net result is in the cell only ferric is left. Now this ferric is will be used to make myoglobin and hemoglobin, and if not needed, extra of iron is there, it get again converted into, will bind with apoferritin. Apoferritin will combine with iron and it will make ferritin, which is this iron storage form. And this ferric will be converted into ferrous to make hemoglobin and myoglobin. So this how ultimately iron from the diet reaches the place where it is to be needed. It's a very complicated. As in the very beginning I told you, is a gray area for 99% students. I hope you have understood it very nicely, and if you're not, see this part of the lecture again. Better if you make your notes, then you will not forget. Okay, well, having learned the difficult part of iron metabolism, so now let us see what are the clinical features of iron deficiency anemia. All features of any anemia like fatigue, malaise, shortness of breath, or pain chest, especially in elderly people with severe anemia. They can have pain chest. Why they have pain chest? This is the coronary artery. This is the myocardium. They develop a type of angina, to be more precise. There's no, maybe coronaries are normal, but whatever blood is going, hemoglobin is highly reduced. So highly reduced hemoglobin is there. HB level is highly reduced. So there is no oxygen. So ultimately no oxygen, the patient will go, a patient will walk, oxygen demand increases, but supply is reduced because this, whatever HB coming has no oxygen, the patient will develop tissue ischemia, and that will develop a type of angina. Now there are certain features which are there exclusively in iron deficiency anemia, especially like angular cheilitis. There are cracks in the angle of the mouth. This is also known as angular stomatitis, or the tongue is totally atrophic. You can normally in the tongue we have papilla-like growth are there in tongue, but here all papilla are lost and so-called atrophic glossitis is there. Okay, they are seen in iron deficiency anemia. Pica is a common to see in those who have iron deficiency anemia, especially in children who play in the park outside. It's a type of eating disorder. They tend to eat like hair, dirt, and paint, chips, etc., or maybe in the soil also. Okay, that's a pica is again due to iron deficiency anemia. You can see here the child is trying to eat the soil. Colinekia, no, and this you can say spoon-like nails are there. You can see spoon-like nails. Colinekia is the one, the classical feature. If you get this word in a case of anemia, you are 99.9% you are dealing with iron deficiency anemia. Brittle hair are again very common in iron deficiency anemia. Plummer-Vinson syndrome is the type of post-cricoid web. Is again very strongly associated with iron deficiency anemia. Again, if you get this word, you are dealing with iron deficiency anemia. But thing is, this is a pre-malignant condition. It can develop into cancer in later. So remember, this is a pre-malignant condition. So a quick recap of the last minute revision point, what we learned in this. We get angular stomatitis, atrophic glossitis, pica, colinekia, brittle nail, and Plummer-Vinson syndrome. And regarding the LMRP of the iron metabolism, I discuss after each slide summary has already been given to you. Well, I'll be continuing about the investigation in our next part of iron deficiency anemia. That is IDA next session, RB. Thank you very much.